Bismillahirrahmanirrahim. I am Dr. Mohamed Ibrahim, Assistant Professor of Obstetrics and Gynecology, Mansoura University. Our topic for today is fetal birth injuries. We will start with cranial and intracranial injuries, which includes caput saxodynium and cephal hematoma. For the definition of cephal hematoma, this is a collection of blood outside the bony skull. Causes include trauma, more commonly in the instrumental deliveries like forceps and abnormal head position. For the site of accumulation, we have the subperiosteal hematoma is limited to the area bound by the sutures. Differential diagnosis from caput saxodynium, which occurs normally or artificial with use of venous delivery. For the treatment, we can do expectant treatment using hot compresses, anticoagulants, antibiotics, blood transfusion if severe anemia develops, and we should do X-ray to rule out fractures. For the surgical intervention, when bleeding is excessive or progressive, we should do surgical intervention to stop source of bleeding. This is a photo which delineate different sites of hematoma formation and comparing caput saxodynium with the cephal hematoma. The third one is intracranial hemorrhage. Etiology includes prematurity and preterm labor, which is the commonest cause. This is owing to the prematurity of the blood vessels, rapid compression and decompression of the head, like in breech delivery or precipitate labor, excessive molding or marked compression using forceps, skull fractures, asphyxia, which leads to anoxia and degeneration of the brain cells and the blood vessels, blood diseases. Site of bleeding, subdural, subarachnoid, intraventricular, and intracerebral. These are common sites where intracranial hemorrhage occurs. For complications, we have shock and death, which may occur from respiratory complications due to compression on the respiratory centers, and we have nervous complications with cerebral palsy, epilepsy, and mental retardation. For the diagnosis, clinical picture, the neonate usually presented with high-pitched cry, convulsions, spasticity, recurrent apnea, and bulging of the fontanelles owing to the increased intracranial pressure. For the investigations, we should do CT scan on the brain to find the site of hematoma and its extension. For prevention, we should administer vitamin K 10 milligrams intramuscular to the mother in preterm and breech deliveries, which will pass to the fetus. Avoid traumatic deliveries, do episiotomy in preterm and breech deliveries to avoid compression and decompression, and avoid frequent use of forceps. Treatment will include keeping infant warm, giving oxygen therapy, vitamin K supplementation, prophylactic antibiotics to guard against infection, hypertonic solutions to decrease cerebral edema. We can use magnesium sulfate to decrease edema and convulsions, and sometimes we sort for anticonvulsant like hydantoin and diazepam. Next, we'll talk about bone and joint injuries. Starting with the skull fractures. This is due to pressure by forceps or breech extraction, fracture of the spine with excessive traction for the aftercoming head or forecoming head, which will injure the cervical spines. Fracture clavicle occur in breech delivery and shoulder dystocia, where we do intended fracture of the clavicle to allow delivery of the shoulders. Dislocation of shoulders occurs during bringing down an arm, like in case of shoulder dystocia. Fracture humerus and femur during breech extraction. fracture of lower jaw, malar bones, and nose in the aftercoming head of the breech delivery, and dislocation of lower jaw occurs in breech delivery. For soft tissue injuries, we have nerve injuries, facial nerve injury, which represents by Bell's palsy due to pressure on the facial nerve at its exit from the sternomastoid foramen by the blades of forceps. The second is brachial plexus injury, which is a commonest type of nerve injury. Etiology is caused by excessive traction on the nerve roots of the brachial plexus, either by lateral flexion of the head during delivery of shoulders or by jaw flexion shoulder traction in the aftercoming head delivery in breech delivery. Over traction of the head in the occipito-posterior position without rotation of the anterior shoulder, which will twist the neck. We have different clinical types, of which the most common is herpes palsy and clumbex paralysis. To differentiate herpes from clumbex paralysis, herpes is more common, while the clumbex one is less common. There is injury in the cervical 5 and 6 roots in the herpes palsy, while injury occurs for the 7th, 8th, and the first thoracic root in the clumbex paralysis. The shape of the upper limb, there will be upper limb drops beside trunk and is internally rotated with flexed wrist, policeman's or porter tip hand. While in the clumbex paralysis, it leads to paralysis of the small muscles of the hand, weakness in the long flexors and or extensors of the wrist and fingers. For the treatment, we do support to prevent stretching of the paralyzed muscle, and this should start as early as we diagnose the brachial plexus injury. Physiotherapy, doing massage, exercise, thoracic stimulation. If we started early, the results are good. And sometimes we do plastic surgery for the permanent paralysis and deforms. After nerve injuries, we have muscle injuries, sternomastoid hematoma, which may occur due to excessive lateral flexion of the head to deliver anterior shoulder during vertex and breech deliveries. Visceral injuries, including injury of liver, suprarenal gland, intestinal injury, spleen, kidney, lungs during breech delivery due to vigorous manipulation of the fragile neonate. Others include injury of the eye, eyelids, ears, and face presentation.